I will present the classical response criteria that were developed first by the EDMT group, and I chair this committee, and were published almost 20 years ago in 1998 as an annotation in British Journal Hematology. And then these criteria were modified a little bit by the International Myeloma Working Group. And finally, we will discuss also on minimal residual disease and imaging techniques for minimal residual disease detection over all the session. And concerning my part of the session, I will present the EDMT criteria defining complete remission with negative serum and urine immunofixation, and also the criteria of progression that were not developed before the EDMT criteria. And then I will come with the modifications by the International Myeloma Working Group. They introduced the stringent CR, so negative immunofixation in serum and urine plus normal free light chain ratio and no clonal plasma cells in the bone marrow. And also they defined VGPR, that is a deeper degree of response than partial response, so it's more demanding. And finally, I will present also the characteristics of the oligoclonal reconstitution. This is the appearance of M protein bands, oligoclonal bands, not related with the myeloma protein, but there may be confusion. So can be, one can think that this is relapse, and is not a relapse. In fact, is an immune response with a favorable prognosis. These are the basic criteria. So we have to see if the patient is in complete remission or not by immunofixation, if the patient is in VGPR or partial response or progressive disease, with the basic criteria before going to the minimal residual disease and before going to the imaging techniques for minimal residual disease. This is the basic. And I will also focus, and will be the last part of the session in the discussion, on how often the patients should be monitored during treatment and off treatment, and also the tests that should be done during this monitoring. This is the basic. And the minimal residual disease comes later. I will present my clinical practice, so what I do with a particular patient during treatment, induction or maintenance, and also when the patients are off therapy. And so I will tell, during the first 2 years, I follow the patient every 2, every 3 months, depending on the patient have received chemotherapy only or chemotherapy plus autologous transplant. And then from 2 to 3 years, I am seeing the patients every 3 or 4 months. And after 5 years in continuous response, I will follow the patients every 6 months with this and that examinations.